Okay, let's make a start. So, hello everyone. Hi, my name is Mahmoud. I'm one of the neonatal consultants in University Hospital Wisho. I'm also the chair of NeoFOCUS group. So, welcome everyone and thanks for joining. We are very delighted today to have our colleague Aisling Smith. She's one of the neonatal consultants in Chelsea and Westminster. At the moment, and I think shortly you're going to join Rotunda Hospital in Dublin, Ireland. Dr. Smith has completed her PhD in 2021 that focused on the evolution of myocardial performance and pulmonary hemodynamics in various neonatal populations, including infants conceived with assisted reproduction, also infants born to diabetic mothers, and infants with Down syndrome. The perspective of the study of myocardial function and pulmonary hemodynamics in infants with Down syndrome over the first 2 years of age was actually the largest performed to date and was awarded 2023 Royal College of Physicians in Ireland award. So welcome, Aisling, and thanks for joining today, and the floor is yours.
Thank you very much. I'm delighted to be here and thank you very much for the kind invitation. So let me just share my screen with you and we'll get going. Perfect. Can everyone see my slides okay?
Yes.
Excellent. So I'll make a start. So thank you again. Let me just get this ready. Yeah, perfect. So yes, as per the introduction, I'm going to be chatting about myocardial function and pulmonary hemodynamics in infants with Down syndrome. And this work was supported with funding from the Health Research Board and National Children's Research Centre in Ireland. This work was done under Professor Aoife Falcafash in the Rotunda Hospital in Dublin. So with regards to a talk outline, I'll be discussing the etiology of pulmonary hypertension and clinical implications in neonates with Down syndrome, the relationship between diastolic impairment and pulmonary hypertension over the first week of age in babies with Down syndrome, the longitudinal assessment of cardiac function and pulmonary hemodynamics in babies with Down syndrome over their first 2 years of age, the assessment of cardiac function and pulmonary hemodynamics in infants with Down syndrome who required surgical correction for congenital heart disease versus those that did not, and just some pertinent discussion points. So as we all know, Down syndrome is the most common chromosomal abnormality of live-born babies globally, and the estimated incidence of Down syndrome worldwide is 1 in 700 newborns, but the incidence of Down syndrome in Ireland is 1 in 546 live births, which is the highest rate in Europe. And again, we recognise that the cardiovascular system of babies with Down syndrome is characterised by pulmonary hypertension and by ventricular dysfunction over their early neonatal period. And pulmonary hypertension is prevalent in infants with Down syndrome, both with and without congenital heart disease, although the underlying etiology and the timing of presentation may be different between those two groups. So with regards to the etiology of pulmonary hypertension, PH and Down syndrome is a heterogeneous entity resulting from multiple overlapping etiologies. And people with Down syndrome have specific anatomical, physiological, and genetic tendencies that place this population at increased risk of developing PH, both in the early neonatal period or early pulmonary hypertension, or at an older age with the evolution of pulmonary vascular disease or late pulmonary hypertension. And a clinically relevant approach to the diagnosis and management considers the timing of onset and the underlying pathogenesis of pulmonary hypertension as an aberrant process of lung development. So first discussing early pulmonary hypertension, or as we like to think of it, delayed postnatal circulatory transition. So neonates with Down syndrome are born with inherent structural anomalies of their lung tissue, including decreased number of alveoli, decreased number of alveoli in relation to acini, subpleural cysts, as well as decreased vessel density. And in addition to those structural anomalies, the lung tissue from fetuses with Down syndrome overexpress anti-angiogenic factors, and taken together, that could lead to impaired pulmonary vascular growth, which obviously could negatively impact alveolar growth and contribute to their pulmonary hypertension phenotype. And then when we start to consider late pulmonary hypertension in this group, or PH that becomes apparent beyond the first few weeks of age, this is in contrast to early pulmonary hypertension, which is associated with delayed transitioning following birth. Late pulmonary hypertension in children with Down syndrome is characterized by sustained and often progressive elevation of pulmonary arterial pressures that's diagnosed beyond the first few weeks of age. And late pulmonary hypertension may develop in individuals originally diagnosed with early pulmonary hypertension during the newborn period, but it can often develop in individuals with Down syndrome with initial successful postnatal transition that never manifested early signs of pulmonary hypertension. So it's likely that some of the mechanisms of late pulmonary hypertension are superimposed on the aforementioned congenital anomalies of respiratory tissue and lung anti-angiogenic factor expression. But other late pulmonary hypertension etiologies could be linked to, obviously, congenital heart disease with persistent systemic to pulmonary shunts, which lead to increased pulmonary blood flow, chronic hypoxemia. Again, we know people with Down syndrome often have sleep disorders, with sleep disordered breathing affecting between 30 and 75% of children with Down syndrome. We know people with Down syndrome can have, which exists on a spectrum, upper airway obstruction because of mid-face hypoplasia, micrognathia, or their generalized hypotonia. Again, we're aware that people with Down syndrome have altered immune function with decreased number of leukocytes, lymphocytes, and monocytes, and impaired maturation of T lymphocytes. So this places them at an increased risk of recurrent respiratory illness, either viral or bacterial, and that obviously could be upper and lower respiratory tract infections, which can exacerbate evolving pulmonary hypertension. Again, this population is an increased risk of gastroesophageal reflux and aspiration, and pulmonary hemosiderosis can present with a more severe course in individuals with Down syndrome. So taken together, there's a lot of interacting phenotypes and a complex interplay between structural, genetic, and immunological deficiencies which exist in people with Down syndrome, which can result in the evolution of pulmonary hypertension, both in the acute and in the chronic phases. And the reason why this is important is because pulmonary hypertension in the early newborn period in the Down syndrome population is associated with the increased necessity for invasive ventilation, prolonged inhaled nitric oxide therapy, longer hospital admissions, and higher mortality before discharge compared to the general neonatal population. And originally, the incidence of pulmonary hypertension in this group was estimated to lie between 27 and 34%. However, that was likely to be an underestimation based off retrospective studies. And also these studies used an amalgamation of clinical and echocardiographic diagnostic criteria. So our group in Dublin had been looking at little babies with Down syndrome for some period of time, and my colleague Colin Brannock had done initial work in a small group of babies with Down syndrome, looking at their heart function and pulmonary hemodynamics over the first week of age. And all of this work laid the groundwork for my PhD. So we recognized that there was a dearth of longitudinal data describing the evolution of myocardial performance and pulmonary hemodynamics in babies with Down syndrome, both with and without congenital heart disease, over the first 2 years of age. And our hypothesis was that babies with Down syndrome, independent of the presence of congenital heart disease, will demonstrate biventricular myocardial systolic and diastolic impairment and sustained elevation of pulmonary pressures over their first 2 years of age. So the aim of the study was to serially assess left ventricular and right ventricular anthropometry and biventricular performance and measurements of pulmonary hemodynamics in babies with Down syndrome with and without congenital heart disease over their first 2 years of age, and to compare these babies to a cohort of non-Down syndrome healthy controls. So this was a prospective observational study carried out across 3 Tier 3 neonatal units in Dublin. Echo was carried out at 6 time points over their first 2 years of age. So I scanned the babies on day 1, day 2, between day 3 and 5, 6 months, 12 months, and 24 months of age. Some of the echo markers that we looked at to assess pulmonary hypertension included pulmonary artery acceleration time, the PAT index to the right ventricular ejection time, PDA shunt and flow direction, and the left ventricular eccentricity index. And markers of systolic and diastolic function include LV and RV strain, systolic strain rate, early and late diastolic strain rate measurements. So just a little bit more detail on some of these measurements. So firstly, pulmonary artery acceleration time, or PAAT. It's a very useful echo surrogate of pulmonary vascular resistance. PAAT has an inverse relationship to PVR. So the lower the PAAT, that indicates the higher PVR. And it has been validated against right heart catheter measurements in pediatric patients and shown to have a high sensitivity and specificity. So it is a very useful echo surrogate that's readily available for our neonates. Left ventricular eccentricity index, you acquire a short axis parasternal view at the level of the papillary muscles, and you measure the degree of septal wall flattening. And again, it just gives you a more objective assessment of the degree of septal flattening. And obviously, the flatter the septum, the higher the right ventricular pressures. So the higher the left ventricular eccentricity index value, that indicates the higher the right ventricular systolic pressure. So with regards to how we measured the myocardial function, we did this in a number of ways. We used cavity dimensions, our classic ejection fraction, measurements of displacement, such as tricuspid annular plane systolic excursion, or TAPSE, to give us a measure of right ventricular systolic function. We use tissue Doppler imaging, which provides measurements of systolic and diastolic velocities, as well as deformation measurements, which can give us our measurements of strain and strain rate. With regards to deformation analysis, this refers to the change in shape of the myocardium from diastole to systole, and 2D speckle tracking echocardiography provides objective and reliable evaluation of LV and RV systolic and diastolic performance. So myocardial strain is the term which quantifies the degree of myocardial deformation occurring during systole and is expressed as a percentage. And then strain rate refers to the rate at which this myocardial deformation occurs. And we're able to derive these measurements by speckle tracking. So this is specialized software that tracks the motion of the myocardial speckles, and the speckles result from the acoustic backscatter generated by the ultrasound beam hitting the myocardial tissue. And by tracking the movement of those speckles frame over the cardiac cycle, the software will provide us the measurements of strain and strain rate. And we can look at the left ventricle, and we can get global assessment of LV function by assessing strain across 4, 3, and 2 chamber views. And a composite measurement of global longitudinal strain is provided. It's important to recognize that myocardial strain measurements are influenced by your loading conditions. So strain will increase with increasing preload, and it will decrease with an increase in afterload. However, strain rate is relatively load independent, and therefore a closer surrogate of inherent myocardial contractility. And we now are developing normative ranges for a lot of our functional parameters in both the preterm and term populations. So moving on to the results of our study. So we had 130 infants enrolled, 70 were babies with a confirmed diagnosis of Down syndrome, and 60 infants were born without Down syndrome or the controls. And I performed 626 echoes over the study period. So we had a mean gestational age of 37 weeks in our Down syndrome cohort. Our Down syndrome cohort had a significantly lower gestational age. They were more likely to be born before 37 weeks. They had a significantly lower birth weight. The maternal age was higher in the Down syndrome cohort, and we had more male babies in our Down syndrome cohort than our control cohort. With regards to the antenatal detection rate, 33% of babies in our Down syndrome cohort were in antenatal diagnosis. 69% had some form of congenital heart disease, with the most common defect being a ventricular septal defect, followed by an atrial septal defect, and one tetralogy of Fallot. This was quite a healthy population, or healthy cohort of infants with Down syndrome. Only 4% of the Down syndrome cohort required inotropic support, Only 6% required nitric and 9% required invasive ventilation. So overall, this cohort reflects quite a healthy group of infants with Down syndrome. And one baby died over the study period. With regards to following them over their first 2 years of age, 44% of the Down syndrome cohort required a hospital admission before 2 years of age. 20% of these admissions were for surgical correction of congenital heart disease. 24 were a non-congenital heart disease cause, such as, RSV or other respiratory illness. 18% required a post-op ICU admission, and 16% required L-troxin therapy for hypothyroidism. 14% at some point over the first 2 years of age required diuretic therapy. So diving into the hemodynamics and the findings. So first of all, to discuss the relationship between diastolic impairment and pulmonary hypertension in infants with Down syndrome over their first week of age. So prior to this work, the presence of left ventricular diastolic impairment and its relationship to pulmonary hypertension in the Down syndrome cohort was unexplored. So as I've mentioned, we had 70 babies with Down syndrome versus 60 controls, and this study looked at them over their first week of age. So the echoes that were performed on day 1, day 2, and day 3 to 5. And this was published in the Journal of Pediatrics. And just to reiterate, 69% of the babies in the Down syndrome group had some form of congenital heart disease. However, notably, there was no difference detected between the Down syndrome infants with congenital heart disease and the Down syndrome infants without congenital heart disease across any of the 3 echocardiography-derived surrogates of pulmonary hypertension, PAAT, PAATI, or the LVEI at any time point over the first week of age. So when we start looking at some of the data, the babies in the Down syndrome group were more likely to have a PDA, they were more likely to have a larger PDA, more likely to have bidirectional shunting on day 1. They also had significantly lower values of PAAT, significantly lower values of PAAT index to RVET, and significantly higher values of the left ventricular eccentricity index in comparison to the control group on day 1. So overall indicating that their pulmonary arterial pressure markers were higher than the control group on day 1. And in our study, we made a diagnosis of pulmonary hypertension if 2 or more of the pH markers defined as follows were present. So if a PAT was less than 40 milliseconds, if a PAATI was less than 0.25, in the presence of a PDA, the demonstration of bidirectional flow or right to left flow, and an LVEI over 1.8. And on day 1, 84% of babies with Down syndrome met this criteria for pulmonary hypertension in comparison to 15% of the controls. However, by day 3, that had dropped to 28% of the babies with Down syndrome still met this criteria for pulmonary hypertension compared to 0% of the controls. And then looking at what happened over the first week of age or when these babies were getting ready for discharge, in these graphs, the babies with Down syndrome are in red and the controls are in blue. So when we looked at the echo surrogates, we saw that they remained persistently and significantly abnormal in the Down syndrome group over the first week of age. So firstly, looking at the PAAT, what you can see is persistently lower values of PAAT over the first week of age in comparison to the controls. You can see significantly lower values all the way to day 3 to 5 in the Down syndrome group of PAAT to RVET. And again, we see significantly higher values of LVEI in the Down syndrome group that persist over the first week of age. When we wanted to look at left ventricular performance over the first week of age, what we saw was significantly lower values of LV global longitudinal strain in our Down syndrome cohort that didn't normalize by discharge. We saw significantly lower values of our LV systolic strain rate measurements. We also saw evidence of diastolic impairment with lower LV early diastolic strain rate values in the Down syndrome group. Again, that persisted all the way to the first week of age. And again, we saw some evidence of late diastolic impairment with lower values of LV late diastolic strain rate measurements in the Down syndrome group on day 3 to 5 assessment. Looking at right ventricular performance over the first week of age, again, we saw lower values of RV free wall strain in the Down syndrome group across the first week of age, lower values of ORV systolic strain rate, lower values of ORV early diastolic strain rate also. That persisted until discharge. So taken together, we saw persistent biventricular early diastolic impairment in the Down syndrome cohort as exhibited by significantly lower LV and ORV early diastolic strain rates over the first week of age in comparison to controls. And then we wanted to examine, well, what's the relationship between this LV diastolic impairment and their pulmonary hypertension over the first week of age? And what we saw with that LV early diastolic strain rate was independently associated with both PAAT and PAATI while controlling for gestational age, cesarean delivery, and the presence of congenital heart disease. We also saw, so again, in these graphs, the babies with Down syndrome are in red and the babies in the control group are in blue. And just to recap that, the EE ratio provides an estimate of LA, left atrial filling pressures, with higher values indicating elevated left atrial pressure. And this is just unpublished data. So what we saw in these graphs when we're comparing these echo markers is that there was a significant positive correlation between left ventricular early diastolic strain rate and PAAT and the PAAT to ORV-ET ratio. And that's telling us that with worse diastolic function, there's a direct correlation with higher indices of pulmonary hypertension in the Down syndrome cohort. And we also saw that on the bottom graphs, that there was a significant negative correlation between EE ratio and PAAT and the PAAT to ORV-ET ratio. And that's telling us that with higher left atrial pressures, there's a direct correlation with higher indices of pulmonary hypertension in the Down syndrome cohort. These graphs were also looking at the correlation between pulmonary hypertension and right ventricular systolic impairment in infants with Down syndrome on day 1. And what we saw on the top is a significant positive correlation between PAAT measurements and ORV free wall strain and the ORV systolic strain rate. So that's telling you with the higher the pulmonary vascular resistance, the lower the ORV systolic function. And on the bottom graphs, we saw that there was a significant negative correlation between the LVEI measurements and the ORV free wall strain and ORV systolic strain rate. So that's again mirroring the graphs above, that with the higher markers of pulmonary vascular resistance, you had flatter septums, all of which, makes pathophysiological sense. So the kind of tying it all together, the physiological mechanism that we proposed is that in the babies with Down syndrome, their decreased left ventricular diastolic function is leading to increased left atrial pressure, in turn causing pulmonary venous hypertension or congestion, increasing their ORV afterload environment and the pulmonary vascular resistance, and explaining the kind of picture of echo markers and values that we're seeing in this group. So moving on to what happens over the first 2 years of age. So we've demonstrated that this population, babies with Down syndrome, have elevated pulmonary vascular resistance and biventricular dysfunction over their first week of age. That doesn't normalize by hospital discharge, but obviously we wanted to see how does this evolve with increasing age. So this was published also and in 2022. And this was the results of our 3-year prospective study of the 70 babies with Down syndrome compared to the 60 controls. So in these graphs, just to orient you, our controls are still in blue. The red indicates babies with Down syndrome with no congenital heart disease, and the green indicates babies with Down syndrome and congenital heart disease. So, and on the bottom, you see birth 6 months, 12 months, and 2 years of age. So first of all, we're looking at our pulmonary vascular resistance measurements. So what you can see here is that at each time point assessed, the PAAT to ORV-ET ratio was significantly lower in both Down syndrome groups compared to the controls all the way to 2 years of age. And we saw this mirrored in our assessments of the left ventricular eccentricity index, with persistently higher values of LVEI in both Down syndrome cohorts compared to the control group that again persisted all the way to 2 years of age. With regards to assessments of left ventricular function, again, what we see is persistently lower values of left ventricular global longitudinal strain in both Down syndrome groups that persists all the way to 2 years of age. In both groups of babies with Down syndrome, we saw significantly lower left ventricular systolic strain rate measurements at birth and 6 months of age and at 12 months of age. However, the group of babies without congenital heart disease and Down syndrome, theirs seemed to normalize by 2 years of age, but it remained persistently lower in the group that had congenital heart disease at 2 years of age. We also saw ongoing evidence of left ventricular early diastolic impairment in the Down syndrome group. It persisted in both groups up until 6 months of age. And then beyond that point, there was only significantly lower LV early diastolic impairment in the Down syndrome group that had congenital heart disease. And we didn't see any differences at any time point between any of the groups with regards to late diastolic function. On assessment of our right ventricular function over the first 2 years of age, what we saw was significantly lower values of RV free wall strain all the way to 12 months of age in both groups. And then again, only in the babies who had congenital heart disease at 2 years of age. And we also saw persistently lower RV systolic strain rate measurements in both groups of babies with Down syndrome that persisted to a year of age. To mitigate for any potential confounders, confounding effect of prematurity and congenital heart disease in the Down syndrome group, we performed subgroup analysis of the babies with Down syndrome, both those born less than 37 weeks. So we compared the babies born less than 37 weeks and those born greater than 37 weeks. And then we also compared the babies with congenital heart disease versus those without congenital heart disease. And notably, there was no difference in any of the LV or RV markers or markers of PVR between the infants with Down syndrome with gestational age of less than 37 weeks or greater than 37 weeks. And in addition, with the exception of right ventricular length, which was longer in the babies with Down syndrome and congenital heart disease, there was no differences in any of the LV or RV anthropometric or functional measurements or PVR markers between babies with Down syndrome with congenital heart disease versus those without congenital heart disease. And of note, there were 20 infants with Down syndrome born greater than 37 weeks gestation without congenital heart disease. And the differences in LV and RV myocardial performance measurements and PVR markers remain significant between these groups and the control group over the first week of age. And finally, just to quickly discuss cardiac function and pulmonary hemodynamics in infants with Down syndrome requiring surgical correction for congenital heart disease in comparison to those that did not over their first 2 years of age. So we had 13 babies in the Down syndrome group who required surgical correction in comparison to 57 who did not. And the only differences, obviously the babies who required surgical correction, there was obviously the AVSDs and the tetralogies, and obviously a higher use of diuretics in the infants who required surgical correction in comparison to those that did not. But otherwise, between those two groups, there was no difference in gestational age, birth weight, male sex, cesarean section, intubation after delivery, oxygen pre-discharge or oxygenation days, time to enter feeds, or hospital stay. However, when we did look at those infants who required surgical correction versus those who did not, what we saw was significantly lower values of left ventricular global longitudinal strain in the group that required surgical correction. We saw significantly lower left ventricular systolic strain rate measurements and significantly lower LV early diastolic strain rate measurements on day one assessment in the kids who were going to require surgical correction versus those who were not. Looking at what happened over the first 2 years of age, this was actually quite interesting to us. So when we looked at to orientate you in these graphs, the babies with Down syndrome who did not require surgery are in blue, and the babies who had Down syndrome and did require surgery are in red. And again, we're looking at our PVR markers, so our PAAT to RVT. And what you can see is that at no time point was there any difference in these measurements between these two groups of babies with Down syndrome. And again, this is mirrored with our left ventricular eccentricity index values, which at no time point indicates that there was any difference between the groups over their first 2 years of age. As mentioned, we saw initially lower values of LV global longitudinal strain in the group that required surgical correction on day one. And also this persisted all the way to 6 months of age. They had lower left ventricular global longitudinal strain at 6 months of age. However, beyond that time point at 12 months and 2 years of age, this had normalized. However, notably, there was like sustained impairment of their left ventricular systolic strain rate values at all time points assessed in the group that required surgery, thereby indicating that there must be some ongoing contractility issue, inherent contractility issue in the kids who required surgical correction, even after the defect was corrected. With regards to right ventricular function, this was also a kind of unexpected finding. When we looked at the right ventricular free wall longitudinal strain, what we saw initially that there was no difference between the groups. What we saw evolving right ventricular systolic impairment in the babies with Down syndrome that required surgical correction, with significantly lower values at 12 months and 2 years of age after their surgery. And again, this was also noted in evolving contractile impairment, perhaps in that group, because there was significantly lower values of ORV systolic strain rate measurements in the group that required surgery compared to those that did not at 12 months and 2 years of age. So moving on to the discussion, to the best of our knowledge, this study is the largest prospective study ever performed on longitudinal myocardial function and pulmonary hemodynamics in infants with Down syndrome from birth to 2 years of age. The study adds new insights to the canon of knowledge on myocardial function and pulmonary hemodynamics in infants and children with Down syndrome. Longitudinal echo identified sustained abnormalities and indices of pulmonary hypertension and biventricular systolic and diastolic performance in babies with Down syndrome compared to controls, irrespective of structural cardiac disease, that do not normalize by 2 years of age. And this is important nuance, which was missing in the available literature. The findings that infants with Down syndrome who required surgical correction of congenital heart disease display sustained left ventricular systolic contractility impairment from birth and evolving ORV systolic contractility impairment from 1 year of age to 2 years of age also further distinguish this group as a particularly vulnerable one within the overall Down syndrome group. There's limited data regarding the biological underpinnings of such observations. So a long time ago, in 1986, a study of 15 individuals with Down syndrome without congenital heart disease, in this study, they compared 15 age and sex matched controls, and they demonstrated that the average weight of the hearts in the Down syndrome group was only 79% of control values. And a murine model of trisomy 21 revealed that the quadriceps femoris skeletal fibers displayed structural alterations of their mitochondria and myonuclei similar to those documented in age-related sarcopenia. So the implications of our research are that a wider and greater awareness of such cardiorespiratory vulnerabilities in the neonatal and pediatric Down syndrome population should be promoted. And it may prompt clinicians to monitor all babies and children with Down syndrome more closely, and not only those with congenital heart disease. And as such, it is vital that clinicians accurately detect myocardial impairment and pulmonary hypertension early, before the appearance of clinically overt disease, to afford babies and children with Down syndrome the opportunity to benefit from effective management strategies. And I'm currently working on an updated national cardiovascular surveillance guideline in Ireland for children and infants with Down syndrome as a result of our work. So thank you very much for your attention, and I would very much welcome any questions you may have.
Perfect. Thank you so much, Aisling, for this fantastic talk and the great work that you have done with your colleagues and the wealth of data that you came up with. So really impressive work. Well done.
Thank you.
I'm just gonna open the floor for some questions until people come in, pitch in. Obviously, looking at your data, you clearly identified there is a cohort of babies with Down syndrome that are vulnerable with myocardial dysfunction. So now what are we going to do with that? So what are the plans for following up? Are we going to screen every single baby with Down syndrome? How much follow-up are we going to offer them? And what are the treatment options that you suggest?
Yeah, I mean, I think that's $1 million question. I mean, I think what's interesting, there's a few interesting points. First of all, like our study reflects actually quite a healthy population of children with Down syndrome. So this is like the best that it could possibly be, if that makes sense, because such a small, like less than 10% of them even needed to be intubated. This was not a sick cohort of babies with Down syndrome. The vast majority of them just had some feeding issues, etc., but they weren't on oxygen or required inotropes. And again, a very small number of them required nitric. So the study reflects quite a healthy group. Your question about what do we do with this information, it's tricky because like we're neonatologists, we're not pediatric cardiologists. It's not us who is going to follow them. But I think what it does emphasize is that it's not just the children with congenital heart disease, it's all of them. So the kind of, obviously I've been liaising with the pediatric cardiology colleagues at home in Ireland, and there will be a plan to offer the children without structural cardiac disease increased surveillance. There's yet to be decisions. It's their service, it's their department and their resources. So it's for them to decide how frequent that might be. But I think even a greater knowledge of the fact that these children are vulnerable. For example, if they were admitted with pneumonia or something like that, maybe it would be worthwhile also getting an echo to assess pulmonary pressures. And, you know, if the child is presenting with frequent infections or frequent episodes of deterioration, that might be a trigger point to get an echo, even if you know that the heart is structurally normal. And then insofar as like what treatment options are available, really it will be optimizing pulmonary vascular resistance by all of the means that we know that we can. Like, you know, for example, do we need to get our respiratory colleagues in to give advice on nighttime CPAP? Or if the baby has recurrent aspiration from gastroesophageal reflux, should we be trying to assist with that? You know, is there recurrent infections? Are we encouraging them to get vaccinated? So I think insofar, like, the work is very interesting, but I only follow these children till they were 2. It will be very interesting to know what are they like at 5 or 10 or 20. But and it's also for us to work closely with our general pediatric colleagues, our pediatric cardiology colleagues, and basically just promote the knowledge that all of them should be followed. They're a vulnerable group. And if they do end up in ICU, they have a higher chance of morbidity, a higher chance of mortality, a higher chance of going on to ECMO. So if you can be keeping an eye on pulmonary pressures and optimizing those things for them, hopefully you might catch things earlier or they might not get as sick. But I think it's a big area that has to be adjusted to what resources are available and what's reasonable for a service. Yeah.
Absolutely. Thanks, Aisling. I think you opened the door for lots of collaboration with MDT, you know, teams, and we'll be really looking forward to your guidelines when you finalize them. So
on my extensive to-do list.
Yeah, that would be amazing. Thank you. We've got some hands up. So Sol, do you want to come in?
Hello, Ashley. Thank you very much. And I'm not surprised Irish going back to Ireland. And it's so nice to see the familiar names from the 10 years ago in Dublin. And just a remark on you wondering in the cardiology waters, if I remember, although I'm not going to be very happy, they were up to the gills already in the work they had at that stage in the Cromlin. Although frankly, but yep, they do. And it's definitely, of course, Mahmoud stole my question about what does it mean, but I think you very nicely explained, you know, that what we need to look at, and especially when the ones I really like that when they get admitted and with the pulmonary conditions, which means that they would definitely be aggravated the left and the right ventricular function. And if anything, the PH is actually probably from the left ventricular failure more than from the right, so which means like a sludging. And that definitely would be the way to pediatric colleagues or respiratory colleagues to do that. But my question would be now, are you ready now to supervise the PhD for somebody who is going to be doing now from 4 to 5 for the same population?
Yeah, I'd love to.
5 or 6 or 8.
I'd love to, but do you know what's very interesting? It's just, so actually the study that we wanted to do to follow on from this was actually, we wanted to look at sildenafil. So we had put together a whole like grant proposal, and we wanted to do an observational study on the use of oral sildenafil from birth over the first like 6 months or a year of age to see, and then follow kids, like obviously have a control group, have an intervention group, follow them for the first year of age. But we cannot get funding for it. So it's we can't get funding for it. So like we've tried twice. I'll try again. But basically it's I mean, to be frank, it seems like sometimes there isn't a lot of taste to do research in individuals with Down syndrome, which is such a shame, because obviously it'd be nice to see, like, is it even amenable to treatment? You know, is it safe to give these kids sildenafil? Does it actually, reduce PVR or those kind of things? But we, at the minute, we can't get funding. So, but yeah, I'd love to do more research on it for sure. And especially, like, again, I think all of us naturally would have assumed that if a child had a congenital heart defect that was a left to right shunt and contributing to increased pulmonary blood flow, that correcting the shunt might reduce or fix PVR. But what the work is showing is that this is something inherent. Like, obviously, it's a good thing to close the shunt, and you have to close the shunt, but it's not the be all and end all. It's a lot more complicated than just a left to right shunt.
Thank you very much.
Abhijit?
Hi, Isley. Fantastic work and fantastic presentation. So I'm also involved in doing this speckle tracking in our unit in Glasgow. So my question to you is, did you have a look at the twist values in these babies?
Yes.
And did you see, so we are not particularly looking at the Down syndrome. We are looking at the CDH babies here. And it's we haven't done the full statistics as of yet, but what we are seeing a pattern of, overcompensation by the twisting of the myocardium. So I'm just curious, what you have seen in your cohort of babies?
Yeah, on the longitudinal assessments, we didn't find any difference in the rotation. So I just didn't present it here. But it was interesting because initially Column's initial work found that there was differences in twist, but that was in a smaller cohort. And when we didn't find any differences, honestly, we were anticipating finding some differences, but we didn't. And I don't know why, but yeah, it was something we looked at.
Right. So when you say you didn't find any differences, is it the same number you are getting as the control group, or you're getting?
Yes.
Okay, cool.
Yeah.
Right.
Column had found it initially in a smaller group, but then when I did the bigger one and over time, we found no differences in the Down syndrome versus controls.
Yeah. So, our preliminary, and again, as I said, like, we haven't run the statistics, but just, looking at the numbers, it looks like when the left ventricular GLSs are dropping, and we can still see that, the blood pressure for first 24 hours are reasonable, not the ideal. We can see there's an overcompensation by the twisting mechanism of the left ventricle.
Yeah. I'm just wondering though, and I've often thought this, like, is the reason I didn't see the Down syndrome babies' LV twist compensatory mechanism kick in because their myocardium is inherently different? Like, maybe, like, babies with Down syndrome are floppy, so clearly their muscle is different. Yeah. And if they also have inherent diastolic impairment, maybe they don't have the same compensatory mechanisms available to them than other genetically normal people might have, maybe that's why we didn't see it. But I don't know.
Yeah, lovely.
It's interesting though.
It is, yeah. Right. Thank you so much.
Thank you.
Vikas?
Hello, I'm Vikash. I'm one of the neonatal consultant at Medway. Other than neonatal hemodynamics, my interest is also to follow congenital heart disease babies. So I've got a huge pool of patients post ABSD, which we see in our clinics. And it's really fascinating. If I understand it correct, is in your follow-up study, you have demonstrated going backwards from LV through longitudinal LV strain, that LV diastolic dysfunction is impaired, followed by EE dash ratio. You managed to show that the LA pressures are, as a result of which LA pressures are high. And then you have demonstrated your evidence of pulmonary hypertension by various indices like PAT is to RVT, and your eccentricity index. Am I correct in understanding that?
Yeah. So what we saw was, like, as the PVR got worse, that was correlated with decreased RV systolic function, which, you know, makes sense. And that there was a relationship between the PVR markers and the diastolic impairment.
Mm-hmm.
Yeah.
So is the what I'm trying to understand is in your study, is there a correlation to suggest that the origin of high PVR in trisomy 21 is primarily due to LV diastolic dysfunction in Down syndrome?
Yeah, I'm not sure I'd go so far as to say it's the primary, but I would definitely say it's a major like contributor to the PVR phenotype, because I think like as I chatted about, like there's a lot of reasons why these little babies have acute and chronic pulmonary hypertension. Like the lung tissue is fundamentally different, you know, like they have lower numbers of alveoli, etc., etc. But I think one of the new pieces of information that our study added was that also they have inherent LV diastolic impairment. And then obviously that's causing increased left atrial pressures, pulmonary venous congestion, and like the worse the PVR markers, the lower the RV systolic function was. You know what I mean? So it all kind of makes sense, and it all comes right together, and we saw those significant correlates. So I guess all I'm suggesting is that it's another contributory mechanism to their pulmonary hypertension phenotype. But I mean, they're complex babies, and even like the late pulmonary hypertension kids, like you have to think about gastroesophageal reflux, aspiration, recurrent infection. You know, it's not going to just be one thing. It's going to be an interplay amongst all of these things. But I suppose our work is just, you know, suggesting to have a look at that as well and to consider. Yeah.
No, absolutely agree with that. The reason I'm asking you this question is few of it is in as pediatric cardiologists, there's always a thought process in this mind that these babies are prone to have pulmonary hypertension, and as they grow older, it's going to get worse. Pulmonary hypertension, they have all the risk factors. If they smoke or they have anything problem, any underlying other pathologies, they are much more worse than their cohort of normal patients or with similar diseases. So that's well established. But what people don't think is it more because of left atrial high pressures and pulmonary venous hypertension, or it is secondary to pulmonary arterial hypertension, because the direction of the treatment would be different. And interestingly, you mentioned about sildenafil study, and I can share your angst about it, because when I started as a new consultant in Bristol in 2014, one of the project I wanted to do with Rob Tullow was something called Springs trial, and it was to be funded by Pfizer. So use of sildenafil in BPD babies, and I know we kept on trying, and then I lost my whole zeal and moved on. I never looked back, but it is a bit frustrating with sildenafil and a trial. You know, getting approval for that. So please don't get disheartened with my
I'll try again when I'm back in Dublin. I'll try again. Yeah.
Yeah. But hopefully you can get.
It was Afif as well. Like it was like we're all part of the same group.
Yeah.
Obviously, like Afif is my mentor. Yeah.
It would be interesting to see. Did you notice in your global strain, because in a clinic when these patients come, all we talk to the parents is how they're doing clinically. So questions are directed towards the exercise tolerance. Their growth, but was there any correlation with your global strain number and their clinical functioning?
No. So I asked, so when I saw these kids back at 6 months, a year, and 2 years, and I would always ask questions about hospital admissions, you know, significant illnesses, what medications they were on. I weighed them. So, and like we didn't see any, because obviously we wanted to know, like, if the kids have worse markers of PVR, are they the ones who are ending up in ICU or getting intubated? In fairness, like, there's 70 kids, but like, again, how frequent is an PICU admission, you know, and I only follow them up till 2 years of age. I think if you really wanted that kind of data, you'd probably need a few hundred kids, you know what I mean? And then 10 of them might get PICU admissions, and how many of them end up on ECMO? You know, it would just take you a long time to gather that massive database so that you could start tying the echo PVR or the echo surrogates of function
Absolutely.
to real life clinical meaning. So no, I mean, we did our best to like look into it, but I think my numbers weren't large enough.
I know, and the current practice for the cardiologists are that they ask for the symptoms, and if symptoms are not that great, then they put the baby under an MRI scanner. Because for the function, they only trust MRI, and for pressures, the only thing they trust is the cath lab. That's what and these days they have access to hybrid cath labs where they do both of together. Just for my personal learning, because I do EE dash ratio quite a lot, what numbers are you worried of increased left atrial pressure? For me, I use number 12. Anything more than 12, I worry. So in your study, what numbers are you using for increased left atrial pressures?
Yeah, I think it was around the same. Yeah.
12. Anything more than 12. And what was the highest in the worst numbers?
Oh gosh, I'd have to look back. I'd have to go back.
That's what I was thinking. So I use number as more than 12 because there's not much data in babies in first 10 days of life, and trying to extrapolate in preterm babies, which you don't look into. So, no, thank you so much for that.
Thank you.
Thank you. Amazing study.
Thank you.
Thanks, Bikash. So Abhijit, if you don't mind, just Jay put a question on the chat quickly for Aisling. So he was asking about the probably same kind of note about the LV dysfunction, that this is the one that causes the pulmonary venous congestion leading to high PVR, etc. So he's asking about the management option. If you think those are with the LV dysfunction, we know from the LV kind of post-capillary phenotype, they're not great candidate for NO. So would that make a difference for your treatment approach?
Yeah. So if I'm understanding correctly, Louis asking about the use of nitric to help with the, yes. Okay. So myself and Neil Patel are actually in the middle of writing up a review on diastolic impairment in neonates, because it's a really understudied, confusing area that I don't think any of us have very good answers for. So specifically, Louis is asking about diastolic impairment in Down syndrome and if nitric was work. I think nitric is more for like pulmonary arterial hypertension. You know, nitric is effective in acute pulmonary hypertension. And we all know clinically, like nitric, you put it on and it'll either work in the first hour or so, or it's unlikely to work. So the kind of mechanism for LV diastolic impairment, I guess, if you think it's a contributor to an acute pulmonary hypertensive episode, then stuff like obviously don't overfill the baby. So think about volume, because if they have diastolic impairment, you don't want to flood. They're like in a form of heart failure, so you don't want to overfill them. And then rate limiting. So again, you don't want the baby running tachycardic. Perhaps, you know, look at if you're using adrenaline or those kind of things, you don't want them running too tacky. Look after pain. Do they need sedation? Make sure they're not septic, those kind of things. But insofar as the phenotype going forward, when the kid is, you know, older, I don't think anyone knows. I don't think anyone knows in general how to manage diastolic impairment in neonates. You know, and there's like Neil and I are doing a review on it at the minute. Like even the adults, I'm not sure they're entirely clear, because they kind of term it as like LV failure with preserved ejection fraction. But it's not entirely clear how they manage it either. So I think it's just a confusing area that there needs to be more research on. I mean, physiologically, it makes sense to not volume overload a patient who has bad LV diastolic performance. And it also makes physiological sense to not have them tachycardic. But then okay, so what medications would you have available to you? Beta blockers? Do you beta block them? Okay, like when do you decide to beta block them? How long do you beta block them for? What's your threshold? How do you measure its success? You know, I honestly don't think we have the data. But nitric to me is an acute phase thing. Yeah.
Okay, thank you. Abhijit?
Sorry, Ali, I have to come back again. A part of my question is answered already. The second part is about the left atrial strain. Did you have a look at the left atrial strain with the left ventricular diastolic dysfunction and any correlation?
I didn't, but one of AFIF's trainees is doing a study on LA strain at the moment in the preterm babies. And I've already thought when I go home, I must pull out my Down syndrome images and do left atrial strain on them, because that would be really interesting. I don't know why we didn't do it at the time. We just didn't think about it. But no, definitely. I think when I get home and I'm back on the Echo Pack, it's definitely something I want to look into. Yeah, thank you.
Great. Lovely. Thank you.
Perfect. I can't see any more hands up. So that was fantastic talk. Thank you so much, Aisling, for this.
Mahmood, before you guys go, can I ask one final question?
Okay.
I didn't ask last time because I was eating already too much of your time.
That's fine.
So one of the things which we always get reported, and I've seen it few times, this baby is trisomy 21. You know, these, in my mind, evolutionary medicine, you think this is a baby, though they have a genetic mutation or an anomaly, they have survived, over hundreds and thousands of years of evolution, and they are the largest inherited, I would say, congenital disease, heart disease group of a cohort of a patient. So, and they somehow have some protective mechanisms, and a lot of time we have seen them having auto banding, the babies with AVASD having auto banding. You have seen the acceleration in the pulmonary arteries. So these, or because sometimes the babies without trisomy 21, the surgeons put a band around them, and trisomy 21 reported to us.
Oh, you're muted. You're muted. There, you're unmuted. Yeah.
So were you able to hear anything at all? Because I've been talking for last.
No. So you were saying that the babies without Down syndrome, the surgeons often have to band them, but that the Down syndrome kids have often auto-banded. Yeah.
So did you see anything like that? And do you think this auto-banding is all about increasing PVR secondary to LV dysfunction?
It's not something I specifically looked at. Yeah, it's not something I specifically looked at. I guess that's more like a kind of cardiothoracic or cardiology interest. So apologies, no, it's not something I specifically
But did you have any experience of increased acceleration in the pulmonary arteries in your babies when you saw them at 7 days or 15 days of life?
Well, yeah. Well, I mean, I guess my assessment of that was the pulmonary artery acceleration time, or one of the measurements of that. Yeah, but that's more like a PVR assessment. Yeah.
No, thank you so much for that. Thank you.
Thank you.
Fantastic. Thank you so much, everyone. Thanks, Aisling, again for your time and this brilliant talk. So it will be uploaded to our YouTube channel. And thank you so much. And we'll see you again in the next meeting. Okay.
Thanks for having me.
Take care, everyone. Bye-bye.
Thank you, everyone. Bye.
Fantastic talk.
Bye.
Bye-bye.